The best use of PET is in 25 or clinical relapse with or without previous chemotherapy. So here's an example of a huge ovarian tumor that is hypermetabolic, soft tissue within a mass that is partially cystic, big mucinous tumor of the ovary. And if you'll look, there are little areas here along the peritoneal surface with soft tissue thickening. This patient had peritoneal spread of tumor. So you look carefully for every little thing you can see. This looks very similar, but this was actually a mucinous colon cancer that had metastasized to the ovary. I showed this case, no, I guess this is a different case, but this is a spread of mucinous tumor within the peritoneal cavity as well as within the omentum, very low metabolic activity. And this patient I showed you with gastric cancer, it had metastasized to the ovary, a Krukenberg tumor. So ovarian masses, how you take them out, an ovarian neoplasm, mucinous ovarian neoplasm, is a big problem. People would like to take them out laparoscopically, but there's always a risk of it spreading. And if you even drop a little bit into the peritoneal cavity, sometimes you convert a patient from a curable tumor to one that is spread intraperitoneally, as happened here. This patient had a laparoscopic removal of an ovarian neoplasm that proved to be cancerous, and this was a follow-up PET scan with a rising CA-125, and lo and behold, there was a metastatic lesion within the mesentery there near the site of the laparoscopic port. Uterine neoplasms come in a number of different varieties. Some of the most common ones will be endometrial carcinoma, uterine sarcoma, and leiomyomas. Endometrial carcinoma is the most common gynecologic malignancy. Most are detected early with a favorable prognosis. Patients present with abnormal bleeding. Most are postmenopausal women, so any postmenopausal woman that's bleeding ought to present to her physician for evaluation. In the premenopausal women, the symptoms are more subtle and often can be dealt with DNC. The treatment, or can be diagnosed with DNC. Treatment is hysterectomy, post-op adjuvant combined chemotherapy and radiation in higher risk tumor. The role of PET in endometrial carcinoma, the specificity is very high, sensitivity is about 50 to 67%. The most compelling use of PET is in evaluating patients with suspected recurrence, however. There's improved selection of patients for definitive radiation treatment for recurrence by using PET. There's about a 40% cure rate without PET-CT and a 90% with PET-CT selection. So you better selected patients without distant metastases. This is an example of a small endometrial carcinoma. These tend to be incredibly hypermetabolic on PET. They tend to be low in attenuation on CT and kind of space occupying. This is another patient, very typical appearance on CT. You've got fluid around this lesion, kind of space occupying, very intensely hypermetabolic on PET. This is another patient, again, a fairly typical appearance on CT, where you have a low attenuating but solid mass within the endometrium. There's kind of an indistinct margin here with a myometrium, which is concerning, and you can see that this is probably spread into the myometrium here, intensely hypermetabolic. When you have uterine fibroids, it can be difficult to diagnose endometrial carcinoma because of compression of the endometrium. This case was a case of endometrial carcinoma in the face of many uterine fibroids, and you can see here how this hypermetabolic lesion could be confused either with another fibroid, very difficult diagnosis in this circumstance. Uterine sarcomas are fairly uncommon cause of uterine cancer. Risk factors include prior pelvic radiation, African American women, or older patients. They consist of a variety of tumors, leiomyosarcomas, endometrial stromal sarcomas, and high-grade undifferentiated endometrial stromal sarcomas, which are actually quite rare. The evidence of medicine and utility of PET in uterine sarcomas is questionable primarily because there are small series and case reports and not a lot of large series showing the value of PET. So it's predominantly because of lack of published evidence in the literature. Leiomyomas or fibroids in postmenopausal women tend to be low in uptake. In premenopausal women, as I mentioned before, they can be variable in uptake and often intense, and are often seen during the first 4 days of the menstrual cycle during the ovulatory phase. Leiomyosarcomas are moderate to intense in FDG uptake, and the magnitude of uptake cannot distinguish between leiomyomas and leiomyosarcomas. So this is an example of a patient with breast cancer. She's got multiple bone metastases, and she had this intensely hypermetabolic mass within her uterus, which we were concerned about. But if you go back 11 years previously and look at her CT scan, this was present then. And this was simply a large fibroid, but boy, is it a hot one. Endometrial stromal sarcoma, low-grade lesions can be slow-growing. I have seen cases where metastatic disease developed in these 15 years after the initial diagnosis. It's often in the lungs at that point, and it tends to be low in metabolic activity. High-grade lesions, endometrial stromal sarcomas, are aggressive, and the prognosis is poor if they're advanced. Surgery is indicated in early disease, and additional CRT may improve survival of early-stage disease. There's very little information regarding the impact of PET in these patients. This is an example of a low-grade endometrial stromal sarcoma. It's very difficult to distinguish this from fibroids. This was removed basically because of the large size, and it was a low-grade endometrial stromal sarcoma. I think the sort of distinguishing features it isn't so much just individual nodules as one big mass. This is a high-grade endometrial stromal sarcoma, and you can see it's got multiple areas of necrosis within it, a very hypermetabolic tumor. And there are lymph nodes involved. You can see one here in the retroperitoneum, another iliac node here. Vulvar and vaginal carcinoma. Vaginal carcinoma, PET does improve detection of the primary tumor and positive lymph nodes over CT. That is old literature, and generally the primary tumor is obvious, but the lymph nodes may not be as obvious by physical exam or by CT. In vulvar carcinoma, compared to the pathology at groin dissection, preoperative PET has a sensitivity of about 50 to 70%, specificity of about 90 to 95%, which is pretty good in terms of specificity. And it has been reported to change management in about 36% of patients both with vaginal and vulvar carcinoma. Vaginal carcinoma, 1 to 2% of gynecologic malignancies. Risk factors include old age, HPV, a history of cervical cancer, diethylstilbestrol as a fetus. Squamous cell carcinoma and adenocarcinomas are both can both be seen, less commonly melanoma and sarcomas. Staging is usually by FIGO staging, plus or minus CT or MR. There's about an 80 to 90% 5-year survival for early stage disease. 80% are present with metastases and they have a worse prognosis. The spread tends to be locally invasive, then to pelvic nodes, periaortic nodes, and hematogenous spread. The treatment is primarily radiation with exentrive surgery and chemoradiation for more advanced disease. This is an example of a patient with vaginal. I don't have a lot of these in my teaching file because they're kind of rare, but this is a patient with vaginal carcinoma. You can see involving the left vaginal apex extending down further. And the magnitude of uptake in this case was not particularly high. I've seen other reports as well, and the uptake is not usually tremendous in these patients. Vulvar carcinoma, 2 to 5% of gynecologic malignancy. Squamous cell is the most common. Risk factors, HPV and older age. The older age patients is not really HPV related. Staging is usually by FIGO criteria. Spread is to inguinal and femoral nodes. This is interesting in vulvar carcinoma, and I think this is important to know. With intrapelvic nodes, so if you have external iliac lymph nodes in vulvar carcinoma, that constitutes stage 4 disease. So it's important to realize that when you're looking at a PET scan in these patients. This is an example of a patient with a large vulvar carcinoma. This spreads into the subcutaneous tissue adjacent to the vulva and also to multiple bilateral lymph nodes. I'm going to conclude with just mentioning PET-CT scanning in pregnancy. Basically, you use the same procedure as other patients, except with a few exceptions. So first of all, it is a safe procedure in pregnancy. It has not been associated with any reported cases of bad outcome to the fetus. And nonetheless, I think it's important to use precautions to further reduce radiation to the fetus. The most important of these is to catheterize the urinary bladder, because the major exposure to the fetus will be the bladder activity. What we do is we put a catheter into the urinary bladder and we give them IV fluids. We start it at about an hour and a half prior to injection of the material and the radiopharmaceutical, and continue it for an hour after the procedure is completed. So we give them, usually 2 to 3 liters of fluid, fairly good amount of fluid. We can also reduce the dose of FDG a bit to 5 millicuries. It is also appropriate to use a low-dose CT if possible in those patients. Remember, 2/3 of the radiation dose from a PET scan comes from the CT. But it's not absolutely necessary, and if you think that the pelvic structures are poorly visualized without contrast, then I would go ahead and do a regular CT. It is also important to calculate and report the dose to the fetus as part of your report, just for your own medical legal protection when you're doing these studies. Now, for gestational trophoblastic disease, there's no data on the value of PET-CT, so I have found nothing in the literature, and I've never seen a case myself. So that concludes my series of lectures, and I'd be happy to answer any questions that you have.
Thank you very much, Professor Dr. Castrin, for this comprehensive and heavy work. You stand for about 3 hours giving lectures like these, covering almost all neoplasms of the trunk. Thank you very much. And now we are starting questions regarding these lectures.
Yes.
Professor Morton, thank you so much for the effort and dedication you put into these lectures. We are all glad that your brother is feeling well and beat the disease. And we wish all your family members more strength and health. First of all, I have a couple of questions. If you, I kind of get the idea behind watchful waiting in prostate cancer. Watchful waiting in prostate cancer, I kind of get that idea. But what's the idea behind active surveillance? Why do I keep someone with already approved cancer waiting?
Okay, so prostate cancer is slow growing in many men. And if it's diagnosed, and it may not need to be treated immediately. If you have a low risk prostate cancer, one that has a low Gleason pattern and a low Gleason score, those patients can survive with prostate cancer and die of old age with their prostate cancer. They don't all need to be treated. And so the idea of active surveillance is in patients who have low risk prostate cancer. So that is a Gleason 3 + 3 = 6, okay? If it's higher than that, then it is not appropriate for active surveillance. But you can watch those patients with low-risk disease, but they have to have, in active surveillance, there are very specific things that need to be done. They have to be re-biopsied on specific schedules. They have to have PSAs performed periodically, digital rectal exam performed periodically, and if they have evidence of progression, then those patients go to surgery or go to external beam radiation or brachytherapy, some sort of definitive treatment, okay?
Okay.
The role of PET in that, PSMA PET is not well established. It probably is fairly useful in some circumstances. I have a colleague who is a urologist who uses it in active surveillance, uses PSMA to identify lesions that light up that would indicate that it's more clinically significant disease, and he does a stereotactic biopsy of that area. And it's been very helpful for him. Watchful waiting is a different process. Watchful waiting is usually in old men, 85 years old, he's got prostate cancer. Do we even need to do anything? Can we just watch him, and if he starts having difficulty?
The proper time for palliative therapy.
Yeah. If he starts having problems, then we can treat him in a palliative manner, but we're not going to be aggressive in him. So that's a different process.
Mm-hmm. Thank you. The second one is, you talked about how PET-CT is better than MRI when, in regards to the pediatric population because of the diaphragmatic and respiratory movements. Do you have some practical tips based on your clinical experience? How do we decrease the incidence of misregistration on PET-CT regarding the respiratory movements?
Well, there is respiratory gating that is possible with PET-CT to reduce the respiratory motion, but in general, the respiration is not a horrible problem. Any motion with MRI, it really degrades your images, but a little bit of motion with PET is not a big problem. But it is possible to do respiratory gating. The problem with respiratory gating is that it takes longer to do that study. Little kids are usually sedated, little teeny children are usually sedated for a PET scan because a PET scan takes about maybe a half hour, and so they're usually sedated for that procedure, so you can image longer. But if you need to do respiratory gating, you can. But the respiratory motion is not usually a horrible problem with PET. But MRI, in my experience, MRI of the liver in a small child is difficult because they breathe, you know, their abdomen goes up. Adults breathe with their chest. Little kids, a lot of abdominal excursion with breathing.
Mm-hmm. Thank you so much, Professor Martin. Thank you.
You're welcome.
Any other questions? Okay.
Thank you, Dr. Catherine, for the outstanding presentation. My question is, what is the cutoff value in peritoneal carcinomatosis, especially after CRT?
I'm sorry, I didn't understand.
What is the cutoff value, SUV max, cutoff value in a peritoneal carcinomatosis, especially after CRT management?
The question is, what is the SUV max with?
Cutoff value.
Cutoff value SUV max in peritoneal carcinomatosis.
In peritoneal carcinomatosis?
Yes.
After CRT, chemoradiotherapy management.
I don't know. Peritoneal carcinoma, so after treatment
Yes.
of peritoneal carcinomatosis, what do you expect to see in terms of the SUV max? Is that the question?
Yes.
With successful treatment. You know, it really helps in peritoneal carcinomatosis to have a preoperative PET or a pre-treatment PET scan. And I'm not aware of any data that supports how much of a decrease you're supposed to see or not, but very often peritoneal carcinomatosis, if it's a mucinous tumor, the uptake even to begin with can be fairly low. You know, that's the problem if it's a mucinous tumor. In my experience, and this is not based on the literature, just in my own experience, peritoneal carcinomatosis that's initially hypermetabolic, usually you'll see a decrease on CT.
Yes.
That it's either completely gone, or I usually judge that more by CT than by PET as to whether it's improved, to be honest with you. If I see residual sites of tumor, I mean, it could be just fibrotic change, but in general, I think CT is probably perfectly adequate for assessing whether there's residual disease. And PET is probably not reliable because many of those patients may have mucinous tumors. That's my own feeling. Does that answer the question?
Yes, thank you.
All right.
Thank you.
I have two last questions. Dr. Catherine? عمرو, okay? I have two questions for me. First, regarding MRI, PET MRI. What it will add or replace PET CT in the future, and in which part in the body it will be preferred? The second question, my subspecialty is genitourinary imaging. I did later research regarding post-nephrectomy, post-RCC nephrectomy, surveillance for metastasis using RCC, using PET-CT. And we found a lot of deposits in strange sites. In USA, it is recommended as a first-line surveillance or survey post-operative to assess metastasis in cases of surgically removed RCC or not.
Well, your first question was PET MRI, and what's the role of that? You know, I know a lot of I mean, there's certainly an advantage in terms of radiation dose. Okay, there's no question about that. And it may be more important in children than adults. But if I look at the staging of pediatric malignancies. And if I look at disease progression, what is typically used is CT and not MRI to begin with. Whole body MRI, it has a lot of potential, and yet I look at the children's hospitals typically do not use whole body MRI for assessing disease response. They use CT. They do a low-dose CT, they give contrast with a low-dose CT. There are certainly some advantages of MRI. For example, prostate. If you did a combined PET CT with, for prostate, or combined PET MR with prostate, that would be fine. In the brain, for example. But the problem with the brain is the brain doesn't move, and you can fuse the MRI to a PET scan. These are both DICOM images, and you can do a fusion after you've acquired them separately. You can fuse them together and view a PET with an MRI of the brain, because it's a perfect, you know, it doesn't change its position with breathing. It stays the same. So in reality, I don't know what the applications are. You know, I have known many people that have both a PET MRI and a PET CT, and the PET MRI sits there and they don't use it. So I don't know what to say about that. I mean, it certainly is a wonderful idea. The MRI that is performed with PET CT is usually not a high, you don't do a lot of different sequences. It's a very simple T1 and T2. And so these are usually, you know, 1.5 T magnets. And so if you think you're going to get a very high quality MRI with that scan, you're probably not going to get it. Not as high a quality, not as extensive a procedure. So, you know, I'm not saying that PET MRI isn't useful, but I'm just saying that in practicality, it's a great idea, but it has not reached widespread use yet. And in fact, whole body MRI for cancer staging and restaging has not really reached widespread use either, even though technically it could be done. So I don't know. I don't know about that. And I couldn't understand your second question. I'm sorry. Was it?
Regarding post-nephrectomy for RCC, do you recommend to use PET-CT as a survey or screening for metastasis? This is my little experience. Is it the first line you recommend? Because we found a lot of strange sites for deposits. Is it satisfactory study to cover whole the body, or you recommend other studies?
Yeah, I would agree with that, yes. Any other questions? Yes.
Dr. Amr Taibi.
Thank you for your interesting lectures. I just want to ask a question. What's your opinion about the delayed scan of the urinary bladder in urinary bladder cancers to eliminate the urine activity and detect small urinary bladder lesions? They sometimes do a delayed scan 2 or 3 hours after the initial scan on the urinary bladder alone, to decrease the urine uptake within the bladder and detect small urinary bladder lesions. So what's your opinion about this technique?
So your question is your question, if you do delayed imaging, do you reduce the urine activity? Is that the question? Or?
In some patients, this was
something.
my second question. In 50% of the patients, the urine activity is eliminated or decreased significantly to detect small lesions, and in other patients, urine activity just persists, and I don't know why.
Right. I mean, there are some ways of reducing urine activity, and when we first started doing PET, we would put a catheter into the bladder and try to remove the urine, and then we would put saline into the bladder to try to dilute the urine that comes in, the new urine that comes in. And that was helpful. But in general, I think that it probably doesn't help to do delayed imaging. You get excretion that's pretty constant throughout the entire interval. So I don't know if there's a good strategy for reducing urine activity with FDG. I really like when I showed you the Posluma May tracer that has reduced urine activity. I think that's going to be very helpful. I mean, the urine activity is the biggest problem is with bladder cancer and also with recurrence. And there's no information on whether bladder cancer can be imaged with Posluma. I don't know that. But the Posluma, which is the radiohybrid PSMA agent, the new agent, that has definitely some advantages with low bladder activity. Now, so at my institution, they continue to be managed by the oncologist, okay? With that, in that if you have a patient that comes a long distance for lutetium therapy, their oncologist is, 500 kilometers away, and you treat him and then you send him back. Done. That's a bit of a problem. So I think that, there are not going to be very many centers that treat with lutetium probably in Egypt. And you're going to, if you start a program, you're going to be receiving patients that come from a fairly wide area. I think that it's important that their own oncologists still be involved very closely in the follow-up of those patients, but you need to receive that data to know, because you're going to be retreating that patient over and over again, and you have to reevaluate them before the next treatment, before the next treatment, before the next treatment, to see whether it's appropriate to continue that. And some of that is going to involve any adverse effects that they might have from the treatment. So we tend to, the oncologists want to maintain control of those patients, okay? They don't want to just give their patient to somebody else, okay? But it's necessary that you maintain a very, very close contact with those oncologists. The other thing that's been very interesting in the United States is that the treatment with radioligand therapy is being done, I would say, half of the time by radiology, nuclear medicine, but the other half of the time by radiation oncology. They're getting very involved in this. This is a new thing, and they get training that's appropriate for doing that, and they're very, very aggressive. Radiology departments are very busy, very busy reading scans. And it takes a lot of effort to treat these patients with lutetium. First of all, you have to evaluate you have to discuss the procedure with the involved study. You should discuss the patient in an interdisciplinary committee that includes their oncologist, radiation oncology, surgery, radiology or nuclear medicine, to decide what the best line of treatment is. And radiology, to be honest with you, radiology in the United States is just saying, I don't have time for this. Let radiation oncology do it. And so at my institution, it's done collaboratively between radiology and nuclear medicine, and treat about half of them, and radiation oncology for the other half. But it's divided. They agreed that they're going to collaborate on it. So that's a problem. Who takes care of the patient? And who has time to take care of the patient? Even more important. It's true.
Thank you very much, Professor Dr. Catherine. We are so appreciating. And now we have a break for 10 or 15 minutes, then continue Dr. Ahmed Ebada, inshallah.